I am Dr. Windsor. Thank you for joining me for a lecture regarding ophthalmic agents commonly used in surgery. By the end of this lecture, you should be able to define terms and abbreviations that are related to the eye and ophthalmic agents. You should also be able to describe the basic anatomy of the eye and discuss common categories of ophthalmic agents that we use in surgery, as well as give examples of each. You should also be able to demonstrate the proper techniques for applying ophthalmic medications. And lastly, you should be able to identify categories of medications used to treat glaucoma. For those of you that have your textbook, Pharmacology for the Surgical Technologist, if you take a peek at box 10.1, you're going to see a list of categories of agents used in ophthalmic surgery. If you don't have your text, they are listed on the slide for you, and they include ophthalmic prep solutions, irrigation solutions and lubricants, viscoelastic agents, Meiotics, Mydriatics and cycloplegics, ophthalmic anti-infectives, anesthetics, anti-glaucoma agents, anti-inflammatory agents, diagnostic agents, and mitomycin. Ophthalmic agents often appear on the back table, and so if you find yourself in an ophthalmic surgery, you're definitely going to be working with many of these agents. So this is why it's important for us to understand the role that the surgical technologist plays in the identification, proper labeling and preparation, and handling of each of these medications. This is even more crucial during ophthalmic procedures because the surgeon is typically using a microscope, and their eyes are going to be looking through the little lenses, and they shouldn't have to look away continuously from the operative field. So what that means is that they're not going to be doing the double checks with their eyeballs like they typically would, because they're going to be looking at this narrow field of vision through the microscope. So what this means for us is that we have to be on our game when we're handling ophthalmic medications. Again, figure 10.1 in your textbook shows the anatomy of the eye, and we're going to discuss each major structure in detail on the upcoming slides. So you will definitely have some visuals on this PowerPoint lecture as well. But I want to remind you that the eye is an extremely complex sensory organ. It's so complex that it takes 6 of our 12 cranial nerves to operate the eye. Remember, its job is going to be to receive visual stimuli from the surroundings and then send those signals to the occipital lobe, the very back lobe of the cerebrum, for interpretation. So let's begin with a brief review of the anatomy of the eye. So the eye works with the help of a number of accessory structures, and those accessory structures include the eyebrows, the eyelids, the eyelashes, and the lacrimal system. Now, the eyebrows, eyelids, and eyelashes, they all serve to protect the eye, and the eyelids and the lacrimal system also moisten the eye. Furthermore, the lacrimal system produces, distributes, and removes the tears, which keeps the eye surfaces moistened and clean. So our story of the structure of the eye itself begins with the conjunctiva. And the conjunctiva is a very thin tissue that covers the front of the eye, and it lines the inside of the eyelids. Now, if you get something in your eye and it starts hurting or burning like crazy, this is because of the conjunctiva is being irritated. You might have heard of conjunctivitis, and conjunctivitis is also called pink eye, and it's a relatively common eye disorder, and it is one of the most communicable infections on the planet. And like the conjunctiva, the bony orbit or the eyebrow ridge is going to serve to protect the eye with the support of the fat and the fascia. So the globe of the eye itself has 3 layers of tissue, and these are referred to as the fibrous, vascular, and nervous layers. Here on this slide, you see them referred to as tunics. So you may also hear them referred to as fibrous tunic, vascular tunic, and nervous tunic. The fibrous outer layer consists of the sclera and the cornea, while the vascular tunic is composed of the iris, the ciliary body, and the choroid, which contains all the vasculature. And then the nervous layer, which is referred to as the retina here on this image, consists of the retina, which is continuous with that optic nerve that exits the back of the eye. So next we're going to take a closer look at each of these structures as well as discuss each of their functions. The outer layer, like I said, or the sclera, is the first part of the fibrous layer. And this is going to give the globe of the eye its nice roundish shape. Now the sclera, you can see circled in green on your screen, is commonly known as the white of the eye. So when you look in the mirror or you look at someone and you see that white part, that is the sclera. Now, the limbus is going to be where the cornea and the sclera meet. All right, and deep below the limbus is a venous sinus, and that is referred to as the canal of Schlemm. So the second part of the fibrous tunic, like I said, is the cornea, and it's circled in red on your screen there. And whereas the sclera is the white of the eye, the cornea is often referred to as the window of the eye. And this is because it is that very frontmost part of the eye, and it is perfectly crystal clear. The cornea does not contain any blood vessels whatsoever, so it has to get its nourishment from the aqueous solution that is produced in the front part of the eye, and it gets its oxygen from the air. The second tissue layer of the eye's globe, remember, is the vascular layer. And the vascular layer of the eye is often called the choroid, and you can see it circled in blue on the right side of this image. It's very, very vascularized. And if you've ever had your picture taken, or you've taken a picture of somebody else and there's what we call red eye, that is thanks to the choroid. So the anterior, or the which is the thickest part of the choroid, is referred to as the ciliary body, and it's circled in red in the bottom left of the image here. You can see that the pinkish red layer that goes all the way around the eye gets really thick near the front. That is called the ciliary body and its muscles. All right, now remember that I mentioned that the cornea gets its nutrients from the aqueous humor. Well, the ciliary body is the body that secretes aqueous humor, and it secretes them from these little doodads called the ciliary processes. And as you can see, that ciliary body, or the muscles of it, attached to the lens of the eye, and this helps the lens to do something called accommodate or accommodation, which is the focusing of the lens. So that helps us see near and far when we are focusing on things. Now, The iris of the eye, which is circled in green on the left side of this image, is between the cornea and the lens, and it is also attached to the ciliary processes. And this is the pretty colored part of our eyeball. And the iris works to change the size of its opening, which is referred to as the pupil. So the pupil's job is to control the amount of light that enters the eye, and it does that by either constricting or dilating. And it is an opening, the pupil. It is not a structure. It's just literally a hole in the muscle that is the iris. And when we're in an environment that doesn't have much light, let's say we are in the movie theater, the iris is going to relax, and that is going to dilate the pupil, and that's going to let in more light. Now, the opposite happens. Let's say we walk out of the movie theater and it's the middle of the afternoon and it's bright and sunny, and now we're in this really well-lit environment. The iris is going to start to constrict down to limit the amount of light that's entering the eye. So the pupil is going to get smaller as the iris constricts down. And when you go from a really dark room to a really bright one, or to the outside where there's sun, you will notice that this the constriction of the iris is not instantaneous, right? Like, it's really bright, like you're squinting for a while as you're waiting for that iris to constrict down so that there's less light entering the eye. The third and deepest layer of the eye, remember I said, is the nervous layer, and that consists of the retina, and that is circled in red on the top right of your screen here. Posteriorly, the retina covers the choroid. Remember, that's the vascular layer. And images that enter the eye are going to be focused on the retina. They actually appear upside down, and then they get switched to right side up when they get interpreted in the brain. So the images are focused on the retina. And there are two different types of photoreceptors in the retina, and these are called the rods and cones. And the rods see grayscale, and the cones see color. And the way I remember this is color starts with C and cones start with C. So when an image lands on the retina, these rods and cones are triggered, right? And then these images are converted to signals that are sent to the brain via the optic nerve for interpretation. So let's talk about the lens. The lens is just posterior to the iris. It's just behind the iris, and it is made entirely of proteins. And these proteins are never, ever, ever replaced. So our eyesight is as good as it's going to get the day we're born, and it starts to get worse every single day of our life. Those proteins are never replaced. So this is why, if we live long enough, we will get cataracts, right? Which are cloudy spots in the lens. Now, the lens is responsible for focusing images on the retina. Like I said, it's typically transparent, and it's covered by a clear fibrous capsule. Kind of think of this like the peanut M&M, where the peanut is kind of the core of the lens, and the candy shell is the covering of the lens. And the lens is held in place by a suspensory ligaments, and those ligaments are called the zonula. So the interior portion of the globe has two cavities. One cavity is the anterior cavity, and the other is the posterior cavity. And these cavities are separated by the lens. So in front or anterior to the lens is the anterior cavity, and behind the lens, posterior, is the posterior cavity. Now, the anterior cavity is further divided into the anterior and posterior chambers, and we're going to talk about that in a little more detail on the next slide. Now, the anterior cavity contains a fluid called aqueous humor, and remember that is secreted by the ciliary processes. It is constantly being produced and constantly being replaced. It drains into a canal called the canal of Schlemm, and there's a trabecular meshwork, which is a well-structured tissue, and it's located in the anterior chamber of the eye, and its job is to serve as the main exit for the aqueous humor. And as that aqueous humor drains forward, it's going to move through the trabecular meshwork and into the canal of Schlemm. Now, this can become a problem if there is a blockage in the meshwork. If there's a blockage, that aqueous humor is not going to be able to exit properly, and so now we're going to have an increase in intraocular pressure, or IOP, in the anterior compartment of the eye, and that is going to lead to something called glaucoma. Now, let's talk a bit about the posterior cavity. The posterior cavity, like I said, is between the lens and the retina, and it contains a really thick fluid called the vitreous humor. And the vitreous humor has a bunch of jobs, and one of those is giving the globe its shape. Other than that, it also helps to keep the retina in place, and it contributes to intraocular pressure. Lastly, vitreous humor is different from aqueous humor in that it is not replaced. So, for instance, if we have a patient that comes in with a torn retina, we're going to have to remove the vitreous humor to be able to work on the retina. So when we're done, we're going to have to replace that vitreous humor, and we'll talk about this a little bit later, but we replace it with some sort of viscoelastic agent. So as I mentioned previously, the anterior cavity has two chambers, an anterior and posterior chamber, and both of those are filled with the aqueous humor. The anterior chamber, which you see circled in blue, is posterior to the cornea. Can you see that it's behind the cornea, but it is in front of the iris? So this is a very popular test question, and you could see it on your CST as well, that the anterior chamber is located posterior to the cornea and interior to the iris. This means that the posterior chamber, circled in green on your screen, is posterior to the iris, behind the iris, and anterior to the lens, in front of the lens. So now we have done a little review of the anatomy of the eye. So we're going to get into the part of this lecture that's dedicated to the various ophthalmic agents that are typically used in the surgical setting. So the eye has a protective barrier that's really similar to the blood-brain barrier, and it's called the blood-eye barrier. This barrier prevents the absorption of most medications that are administered systemically, and as a result, most ophthalmic medications are given topically in the forms of drops, suspensions, or ointments. Medication cycloplegics can also be placed in the conjunctival cul-de-sac after the eye has been anesthetized with local anesthetic drops. Now, the image on the slide illustrates the proper administration of topical ophthalmic solutions and ointments. Once administered, Ophthalmic medications enter the systemic circulation via the conjunctival vessels and nasolacrimal system. Interestingly, almost 80% of ophthalmic medications enter the nasolacrimal system, drain into the mouth and nose, and then enter the stomach, which is where absorption takes place. Sometimes medications might be injected directly into the anterior chamber of the eye, and this is referred to as intracameral injection. It's important to make sure that strict aseptic technique is used when we administer ophthalmic medications. We want to make sure that we don't touch the patient's tissues with the tip of the bottle or the nozzle of the tube or anything like that. If we do, that container is going to be considered contaminated, and we should discard the entire thing immediately after we use it and get another one. Also, touching the tissue with the tip of the bottle could result in a corneal abrasion. Another way to reduce corneal abrasion is to never pass anything directly over the eyes. Instead, we want to pass under the chin or over the head when we're passing. When we use ophthalmic ointment for the very first time, we want to squeeze a little bit of it out, about 1/4 of an inch of medication, before we use it. Now, there's something kind of newish on the scene as far as treatment of the eye, and these are called nanoparticles. And like I said, currently they're an area of intense scientific and medical research. These particles are so small that we measure them in nanometers, and 1 nanometer is 1/100000th of a meter, so very, very small. And these minute particles may be the wave of the future as far as ophthalmic drug delivery. The first category of ophthalmic agents that we're going to learn about is ophthalmic prep solutions. And because the tissue of the eye is so delicate, it requires special prep solutions. One example is betadine ophthalmic 5% prep solution. Betadine ophthalmic is a sterile dark brown liquid that contains 5% povidone iodine, and it is stabilized with glycerin. It's a broad spectrum microbicide, and it can also be used to irrigate the eye. Typically, the ocular region is prepped to include the eyelids, the eyebrows, and the cheeks. We should leave it in contact with the prepped areas for about 2 minutes, and after that we need to irrigate the eye with sterile saline to make sure that we remove any residual prep solution so it doesn't irritate the eye itself. Next on our list of ophthalmic agents is irrigating solutions and lubricants. Remember, the eye is going to be held open with a speculum for the entirety of the surgery. The patient's not going to be able to blink or re-wet their eye themselves. So this can cause the eye to dry out. And because of that, the purpose of irrigating solutions in ophthalmic procedures is to cleanse the operative site, but to also keep the cornea moistened. A common ophthalmic irrigating solution is called basic salt solution, or abbreviated BSS. And it's been my experience that the ST is responsible for periodically re-wetting the eye with BSS throughout the duration of the procedure. Lubricants are agents that come in an ointment form, and they're also used to moisten and protect the eye. Some common ophthalmic lubricants include Lacrolube and also one called Duratears. And this is typically applied to each eye by the anesthesia care provider on patients having general anesthesia. So we're not working in their eyeball. right? They're going to apply it to their eyes, and then the eyes are going to be taped closed, or they're going to put on a special little eye mask or shields to reduce the risk of corneal abrasions. And side note here, we always want to remember not to wipe the eye with a gauze sponge because we could cause a corneal abrasion. The next category of ophthalmic medications is viscoelastic agents. And viscoelastic agents are supplied pre-measured. They come in sterile syringes with blunt tip cannulas, and most require refrigeration until we use them. And on the top right, you can see a variety of viscoelastic agents. Some examples include Helon, Amvisc, OcuCoat, and Viscoat. I have also heard of Duovisc. A lot of them have Visc in their name. So on a test, if you're asked to identify a viscoelastic, there's a good chance that the answer is going to have VISC in the answer. Not if it's Helon or OcuCoat, of course, but there are several that do have the VISC in their name. So these are really thick jelly-like agents, and they're going to be injected into the anterior chamber of the eye to help keep the chamber expanded while they're doing a cataract extraction. They can also be used to replace that vitreous humor that we talked about. Remember when I said vitreous humor does not replace itself. So if we have to remove the vitreous, we can use a viscoelastic agent to replace that. It can also be used as a tamponade as well. They're no longer considered just medications to maintain space and coat ocular tissues. They are an integral part of cataract surgery, and they're being used with newer ophthalmic surgical techniques as well. There are some side effects, and those include a rise in intraocular pressure, corneal edema, or corneal decompensation. Corneal decompensation, you can see it here on the bottom right of your screen, is characterized by this opacity of the cornea, and it's typically a response to a mechanical injury from incidental corneal contact by our instruments during surgery. It could also be caused by a chemical injury or certain drugs, or from residues in detergents that were not rinsed off from our instruments properly. Research suggests that the most common cause of corneal endothelial compensation is during the cataract removal. And if we do have severe corneal endothelial decompensation, the patient is going to require a corneal transplant. So now I want to talk about Meiotics. Meiotics are another type of ophthalmic agent, and they are those that cause the pupil to constrict, or they're going to cause the iris to constrict, which causes the pupil to get smaller, right? So they work by stimulating the sphincter muscle of the iris. And these agents are administered topically or by injection, and some examples are acetylcholine, which is also referred to as Myochol E, pilocarpine, or carbachol. And Meiotics, actually meiosis is the term for constricting of the pupil. That's why these are called Meiotics. And they can also be used intraoperatively when pupillary constriction is indicated, like when we're doing a laser iridectomy, which is a removal of the portion of the iris. Sometimes we do this to treat glaucoma. Occasionally, They're also used to maintain the position of an implanted intraocular lens. We abbreviate that as IOL after a cataract extraction. And because pupil constriction reduces intraocular pressure, Meiotics are often used in the short term to treat glaucoma. There are some side effects, and those can include eye, eyebrow, or eyelid pain, blurred vision, abdominal cramps, and diarrhea. Acetylcholine, like I said, we're still on Meiotics here, is an agent that's available in a solution of mannitol, right? And it's also called Myochol-E, like I said. The mannitol, with its diuretic effect, is going to facilitate the drainage of aqueous humor. And like I said, glaucoma is an increase, is caused by an increase in intraocular pressure. So mannitol might be used to treat chronic glaucoma. It must also be reconstituted immediately before use. So now let's talk a little bit about carbachol. Carbachol is a meiotic that's used topically to reduce intraocular pressure in glaucoma. It can also be injected into the anterior chamber intraoperatively to keep the intraocular lens in place. And then lastly, pilocarpine is administered topically, and it acts directly on the smooth muscle of the iris to stimulate meiosis. Remember, that's the constriction of the pupil. And because pilocarpine increases the flow of aqueous humor through the trabecular meshwork, it is very useful in treating something called open-angle glaucoma. So let's move on to talk about Mydriatics and cycloplegics. Mydriatics and cycloplegics are both paralytic agents that are used to dilate the pupil before ophthalmoscopy. And if you've ever been to the ophthalmologist and had your eyes dilated, they used one of these probably to dilate your eyes. Both Mydriatics and cycloplegics cause mydriasis, which means pupil dilation. And the way that they do that is by paralyzing the sphincter muscle of the iris. Cycloplegics are also going to paralyze the accommodating mechanism. Remember, this means that they won't be able to focus their lens properly, which means patients are going to be unable to see near objects clearly. Some examples include atropine and phenylephrine. Cycloplegics, remember, are those that cause paralysis of the accommodation mechanism. Some examples of those include cyclopentolate and tropicamide. And another thing about cycloplegics and mydriatic agents is that they do have some side effects, which include tachycardia, photophobia, dry mouth, edema, conjunctivitis, and dermatitis. In surgery, agents like these are going to be used to provide access to the eye so that they can see inside the eye. And remember, these are used to dilate the pupil. So the next category of ophthalmic agents is ophthalmic anti-infectives, and most are going to be available in solution and ointment form. Anti-infectives in ointment form are often used to treat external ocular infections. Some common ophthalmic aminoglycosides include gentamicin, neomycin, and tobramycin. Other common ophthalmic anti-infectives include bacitracin, erythromycin, moxifloxacin, gadafloxacin, ciprofloxacin, and ciprofloxacin. And in surgery, anti-infectives are often going to be used to guard against postoperative infection. So there's a good chance it'll be given prophylactically to reduce the chance of post-op infection. Anesthetics are a unique category of ophthalmic agent because they interfere with the normal transmission of pain impulses to the brain. And most ophthalmic surgical procedures are going to require some sort of topical or injected anesthetic agent, as well as sedation and monitoring. So this is why an anesthesia care provider is typically scheduled for most ophthalmic procedures. This is referred to as monitored anesthesia care. Now, way back when, cocaine solution was the topical anesthetic of choice. Today, two common options are tetracaine hydrochloride and proparacaine hydrochloride. Did you notice that both of those end in AINE? This ending can clue you into the medication being a type of anesthesia or anesthetic. Both have an onset of about 1 minute and a duration of 10 to 20 minutes. Both are available in 0.5% ophthalmic solution. And it's important to note that the patient's blink reflex is going to be temporarily lost when these medications are given. Procedures requiring more extensive anesthesia are going to be administered something called a retrobulbar or peribulbar block, and that's the pictures that you see on your screen here. So lidocaine or bupivacaine is typically injected near the optic nerve for the retrobulbar block. As you can see, the top image, that needle that's kind of on the bottom and angling way up towards that optic nerve there. Now, if they're doing a peribulbar block, they're going to be injecting it into the soft tissue above and below the globe of the eye. The anesthesia care provider may add something called hyaluronidase, and this is going to facilitate the infiltration of the anesthetic. Epi might also be added, and remember, epinephrine is a vasoconstrictor. So if they add epi, this is going to prevent the rapid absorption of the anesthetic, which is going to help prolong the block. Two side notes here before we move forward. One, the use of hyaluronidase is contraindicated if malignancy is present. The second thing is that these patients are going to be lightly sedated. So that means they are going to be drifting in and out of like a napping kind of state. They're going to be coherent and somewhat alert. So we want to make sure that we keep talk to a minimum and that we are very careful about what we say. In my experience, most ophthalmologists like it silent in their rooms when they're working on their patients' eyeballs. Another category of ophthalmic agents is anti-glaucoma agents. Remember, glaucoma refers to the group of conditions that's characterized by increased intraocular pressure. We abbreviate that as IOP, intraocular pressure. Now, glaucoma can be caused by an overproduction of aqueous humor or by a blockage in the drainage system. Normal IOP, intraocular pressure, is between 10 and 20 millimeters of mercury. If we have a patient whose pressure in their eye is greater than 25 millimeters of mercury, then that is going to be considered abnormal. When we have excess pressure in the eye, that can damage the optic nerve and that can lead to blindness. And as their name suggests, anti-glaucoma agents work effectively to decrease IOP. Mannitol, which I already mentioned before, is the only anti-glaucoma agent that is used in surgery, and it is an osmotic diuretic. There are several categories of anti-glaucoma agents, and these include Meiotics, beta-adrenergic blockers, diuretics like carbonic anhydrase inhibitors, alpha-adrenergic agonists, and prostaglandin analogs, or PGAs. So we're going to talk about each of these categories in a bit more detail. So anti-glaucoma agents are going to be administered orally or intravenously. Let's talk about osmotic diuretics first. They are a class of anti-glaucoma agents that may be used to treat glaucoma in the short term, and they work by raising the osmotic pressure of blood. So they do this by drawing fluid out of the eye, which is going to lower intraocular pressure. And some of those include mannitol, which I mentioned before, glycerin, and isosorbide. They have a duration of approximately 4 hours. Now, carbonic anhydrase inhibitors. Now, some examples of those include acetylzolamide, brinzolamide, and dorzolamide. And how they work is they interfere with the production of something called carbonic anhydrase. Anytime you see something that ends in the ending A, S, E, that is typically going to clue you in that it is an enzyme. Okay, so carbonic anhydrase is an enzyme that catalyzes the secretion of aqueous humor. So it tells the eye, it tells the ciliary processes to make aqueous humor. As a result, this inhibitor is going to reduce the production of aqueous humor, and that's going to lead to a decrease in the intraocular pressure. It takes about 1 to 2 hours for it to start working, and then it has a duration of about 3 to 5 hours. There are some side effects, which include nausea, lethargy, anorexia, drowsiness, vomiting, and hypokalemia, which, remember, is an abnormally low potassium level. Okay, we're going to switch gears now and talk about alpha-adrenergic agonists. These are also referred to as sympathomimetics. They're another class of anti-glaucoma agents, and they're administered as eye drops. They're considered the third line of treatment for glaucoma, and some examples are apraclonidine, brimonidine, epinephrine, and dipivefrin. And these agents decrease the production of aqueous humor, and they also facilitate the outflow or the drainage, right, of aqueous humor. Couple more left here. Beta-adrenergic blockers. These guys, such as timolol, betoxolol, metoprolol, and levobrinolol, they block beta-adrenergic receptor sites, and this helps to treat glaucoma by reducing aqueous fluid production. All right, kind of the same thing, right? There are some side effects which include ocular irritation, eye pain, headache, decreased corneal sensitivity, dry eye syndrome, and also blurring of the vision. Lastly on our list of anti-glaucoma agents are PGAs. And PGAs are now the first line of medical treatment for glaucoma. They significantly reduce intraocular pressure, and they do this by increasing the outflow of aqueous humor, which is increase in the uveoscleral outflow, which is a different route other than the trabecular meshwork and the canal of Schlemm. And some examples of these include bimatoprost, lananoprost, and travoprost. All right, we are making our way through the various agents. We just have a couple categories left, and here I want to talk about anti-inflammatory agents. And there are two categories that we use in ophthalmology, and they include steroids and non-steroidal anti-inflammatory drugs, NSAIDs. So steroids and NSAIDs. And the general purpose of these anti-inflammatories is to reduce inflammation, right? And swelling postoperatively. So the first class of anti-inflammatory agents, steroids, some of which are shown here, include betamethasone, dexamethasone, and prednisolone. You might have noticed that they all end in O-N-E. Most steroids end in O-N-E, so that can be a clue for you if you're taking a test and you're not sure. But steroids are hormones with a wide range of effects, and they're administered via 4 routes, which include topical, systemic, periocular, and intravitreal. They're used in ophthalmology, like I said, to decrease ocular inflammatory response to trauma, decrease corneal inflammation, and to help protect the eye from excess scarring. Postoperatively, they can also be used to decrease swelling. The use of steroids are contraindicated in the presence of infection because they are not bactericidal. And because of that, they tend to hide the symptoms of an infection, and steroids are going to reduce the immune response. So, because of that, you may see steroids that are available in a combination with antimicrobial agents, and an example of that is Tobradex. And Tobradex is a combination of tobramycin, which is an antibiotic, and dexamethasone, which is a steroid. So let's talk a little bit about NSAIDs. NSAIDs such as Acular, Voltaren, Navanac, and Zybrom are a second class of anti-inflammatory agents, and they are typically used to prevent or treat cystoid macular edema, iritis, and conjunctivitis. They're also used to prevent postoperative inflammation following cataract surgery, and they can possibly be used to inhibit intraoperative meiosis. Remember, that is constriction of the pupil. Lastly, the final class of ophthalmic agents is diagnostic stains. And stains are commonly referred to as dyes, and they are used to mark tissue, and they also serve as a diagnostic tool in ophthalmology. There are several agents that are available for diagnostic use, and some of those examples are fluorescein, rose bengal, lissamine green, and indocyanine green. Ophthalmic dyes are typically instilled topically to diagnose abnormalities of the cornea and conjunctival epithelium, or to locate foreign bodies. Dyes may also be used to observe the flow of aqueous humor or to demonstrate lacrimal system function. Fluorescein is a non-toxic water-soluble dye that is applied to the cornea or conjunctiva to identify denuded areas of epithelium or foreign bodies. It can also be used to diagnose corneal abrasion by staining damaged or diseased corneal tissue bright green, and you can see that in this image here on your screen. Rose Bengal is an even better staining agent for devitalized tissue, and it's used primarily to demarcate the devitalized conjunctival epithelium seen in dry eye syndrome. And lissamine green is pretty much like Rose Bengal. And then the last one, indocyanine green, is a diagnostic dye used primarily for ophthalmic angiography. It's going to be given intravenously outside of surgery to visualize the choroidal vascular network. Thank you for joining me for this lecture regarding ophthalmic agents. As we have learned in this lecture, there are many categories of ophthalmic agents that are used from the sterile field. It is critical that we know the drugs that we're handling as well as their categories and purposes. Equally important, the surgical tech must apply safe medication handling techniques to ensure the best patient outcomes. So I really hope that this lecture contributed to your learning and that you'll join me next time. Until then, take care out there and stay committed to honing your craft as a surgical tech.